Hello, and welcome to Dr. Jeff Talks About Sex and Intimacy, the podcast where we explore the real, raw, and relevant aspects of sexual health, relationships, and everything in between. Thank you for joining us today live, or if you're on the recording, for episode 32, Prostate Cancer and Minorities, What You Need to Know. I want to take a minute to just sincerely thank you for being here. You know, you and your presence is everything. You're the reason this podcast exists. I'm truly grateful for you and for you tuning in and wanting to learn more about this topic. So thank you so much. We're out there on social media, so wherever you are, we're there. If you're on Facebook, if you're on YouTube, X, LinkedIn, Kicks, we're there. If you need to ask a question and you're on X, you can go to LinkedIn, Facebook, Kick, or StreamYard to allow you to send us a question for our guest. We need 100 followers on Facebook. So if you happen to be a Facebook person, the more followers we get, the more we can do on Facebook. We're already on there, but it just allows us to do even more. So please follow us on Facebook. You know, the website has everything that you need to see in terms of previous episodes. If you missed one, you can go back and watch any of, this is number 32, any of the previous 31 episodes. You can watch any of those, pick and choose. You can pull up the calendar and see all the amazing, incredible guests that are coming each Tuesday to join me to enlighten and inform you. So go to the website. Well, listen to us while you're working out, while you're in the car, wherever you are. We're on your favorite music streaming service like Spotify, like Amazon Music, like iHeartRadio. You can't see us, but you can hear us there. So listen to us while you're working out and learn more about sex and intimacy. I just want to remind you, all are welcome here. Regardless of your sexual orientation, your gender identity, or your relationship style, you are whole, you are enough, and you are welcome here in this space. So welcome. The goal of the podcast, well, it's pretty simple. It is to empower and enlighten you with the scientific, evidence-based information you need to improve your sexual health and to deepen your amazing relationships with your loved one, helping you live and love more fully. Well, today's episode tackles a critical and often discussed topic: prostate cancer and minorities. What you need to know. We're here to talk about it because it's such an important topic. Prostate cancer disproportionately affects Black men and other underserved populations. But why? And what can we do to change the outcomes? In this episode, we're going to unpack the structural, clinical, and personal factors that contribute to disparities in prostate cancer screening, treatment, and survivorship. We'll also explore how improving awareness and access to care can help save lives, especially, and this is most important, we want to reach out to our minority communities. So important. My guest today is a friend and colleague. I'm proud to call him my friend and colleague, and that's Dr. Adam Murphy. And he is a board-certified urologist. He's a nationally recognized physician scientist at Northwestern Memorial Hospital in Chicago, where I worked for almost 25 years in the past. He serves as an associate professor of urology at Northwestern University Feinberg School of Medicine, with joint appointments in preventative medicine and medical social sciences. He also serves the veterans where I work at the VA as well, at the Jesse Brown VA. We're both honored to serve our vets there. Dr. Murphy's research focuses on prostate cancer disparities, particularly in African American men, and the role of social determinants of health, vitamin D deficiency, and molecular markers in cancer progression. His work bridges clinical care, public health, and community engagement, bringing both science and humanity to the forefront of equity in men's health. In addition to his NIH-funded research, Dr. Murphy is a passionate educator and advocate for culturally competent care. And that's what we're all about here at this podcast. He's published extensively, testified before policy groups, and remains committed to transforming how we address prostate cancer risk and care across diverse populations. I could not be prouder to welcome my friend and colleague, Dr. Adam Murphy. Welcome, Adam.
Thank you for having me. It's good to see you.
It's great to see you always. I don't see you too often these days at the VA. We seem to be on a little bit different schedules.
Passing the night, yes.
We're both busy, but it's always great to see you. And I thank you for wanting to be here to inform and enlighten our listeners. And so take it away. It's all yours.
Okay. Thank you for having me. And really just glad for the people who are here listening to this topic. It is something that is near and dear to my heart. And while I kind of started off as a person who was focused on kind of Black men's prostate cancer disparities, it became more of an issue where I saw that we all needed kind of more tailored prostate cancer prediction, and race is one of the factors. And I think it's not just for Black men who are at high risk, but Asian men who are at lower risk. But there's variation within Asians, or Hispanics who are at generally lower risk, but there's high risk groups within Hispanic communities. And so I think the beauty of being in a diverse country like the United States is that we can get enough data gathered to really be able to make race-specific, sexual orientation-specific recommendations for kind of the performance of biomarkers, tests, treatments. So I think we're in a good place in American history right now in terms of having this access to data. So I'm going to talk about kind of prostate cancer in ethnic and racial minorities, mainly here, but to cover more than Black men. And then it'll be incidence, mortality, treatment outcomes, and advanced diagnostics that I kind of focus on in my research practice. So we know about the incidence differences that Dr. Albaugh just said, which is that Black men have the highest prostate cancer incidence in the world, 70% higher than white men in the United States. And it's still the leading cause or second leading cause of cancer death in many groups around the world, and regardless of race. And while that reality is there, sometimes the tests we use to define a positive versus a negative test in terms of risk can become tricky to pick, because people who have higher risk of cancer tend to need a lower threshold to define a positive test. If you're thinking about it like a pregnancy test, you want the positive sign to be red, the pregnancy test to look red when they are pregnant and blue when they're not pregnant, or have a plus when they are pregnant and a minus clearly when they're not. And that level where it turns positive should be tailored to the people's race, ethnicity, and other risk factors if we're going to get to precision medicine. So amongst Hispanics, although they're lower, Puerto Ricans are the second highest group in the US, only second to Blacks. And Puerto Ricans are known to have more West African ancestry than many of the other Hispanic subpopulations, like Cuban or even Dominican Republican. So that may be one of the reasons for it. Could be dietary things as well. Amongst Asians who have overall 30% lower incidence of prostate cancer relative to whites in the US, there's still this variability where Japanese have higher risk than Filipino, and they have higher risk than Chinese Americans. And so having this information is coming. And some of it is due to genetics, some of it is due to socioeconomic status and healthcare access, and probably things like diet and vitamin D deficiency and other things. And the mortality rate is higher for Black men, and it's more than double that, 2.2 times the mortality rate of US white men. And that happens even in Chicago, where we have 5 very good academic medical centers within a 5-mile radius of one another. So even with this great access, the mortality rate is still twice as high in Black men in Chicago. There's higher incidence that explains 70% of that higher mortality rate. So if you're 170% more likely to get it and 2.2 times more likely to die of it, a lot of that 220% increase is from the incidence. But access to care does matter. Things within the healthcare systems that have caused medical mistrust amongst minority patients, especially Black men and women, have led to people to be hesitant to go and seek care. And then people are oftentimes diagnosed more later in their disease course. And so that's another reason for the death rate being higher. Hispanic men have a generally lower prostate cancer mortality despite having fairly low screening rates in the US. So there is, again, that protection for Hispanics, but it isn't across all Hispanics, with Puerto Ricans and Mexicans still being higher than US whites. And for Puerto Ricans, the mortality rate is actually higher than US Blacks. Small data sets, because Puerto Ricans are a fairly small subpopulation of US Hispanics, but that was fairly startling to me. And so amongst these subgroups, there is a study that showed that Puerto Ricans have 1.7 times the mortality rate for non-Hispanic whites and 1.5 times higher this hazard ratio, even for non-Hispanic Blacks. That's how different that is. And Mexican Americans are a little lower than that, and Dominicans not significantly higher. So I just want to highlight that knowing your nationality and being aware of your risk, even within a low-risk population, does matter. Talking about, for the people who have cancer and choose to have radical prostatectomy or surgical removal of the prostate and seminal vesicles, which is called a radical prostatectomy, the outcomes in the past were thought to be quite a bit worse for Black men. They would have the cancer come back more often after treatment with radiation or surgery. They have evidence of higher rates of bad features, which we call adverse pathology, where the way it looked under the microscope, called the grade, was more often higher than we thought from the biopsy. So you'd have this worse pathology at the surgery than you expected based off the biopsy results. And then you'd find that, fortunately, a lot of that difference in recurrence, or the cancer coming back, gets eliminated when you go to a high volume center. A place that does a lot of prostate cancer treatment typically does a better job of getting all the cancer cells out with that surgery. And if there's equal access settings like in the VA or military hospitals, you also see some of that recurrence difference go away. So there is some parts of it that are improved when you go to a place that does good work with this and has a lot of patients with this disease. So I think that you'll also find that the quality of life after treatment with surgery is better in providers and in medical hospitals or centers that have more volume of that disease. So it is worth shopping around, I believe, for your cancer treatment, to make sure you go to good surgeons, good radiation oncologists, good providers who know what they're doing and are very used to this. One of the reasons why they think that the prostatectomy outcomes were worse in Black men was because the pelvic anatomy is slightly different, with some studies showing that Black men's pelvises were more narrow and had a smaller diameter than white men. And so it was harder to reach into the pelvis, especially in the days before we did a lot of robotic prostatectomy. But providers also tell me that it's still difficult in African-American patients to get continence, to get men completely dry after surgery. And so for radiotherapy or radiation, there's basically equal rates of the cancer coming back after radiation if you're in a good equal access setting, like the VA or military hospitals, or you're on a clinical trial where everyone gets standardized treatment and a lot of oversight. And so that was shown in 2021, which is really bodes well. And some data suggests that Black men actually do better with radiation than matched white men do with the same kind of aggressiveness of disease. Some of the data, though, in the real world, outside of these equal access centers, suggests that Black men get and other minorities don't complete their radiation at the same rate. So instead of getting the 43, sessions of radiation, people may stop short at 35 or 30, and they're not really getting the same dose, and so that could be responsible for some of the hardships. And I've now gone to the radiation centers and have found why that could be. It's if you're very busy, they try to make sure that the bladder is full when they give the radiation dose, and that the male has had a bowel movement to move the rectum away and to move most of the bladder above the prostate to limit the damage from radiation. But if you're very busy, maybe that isn't done as well. And then there's a hydrogel that is protecting the bowels of the rectum and colon from radiation damage called space ore, which is a gel that doctors can put in between the prostate and the rectum, which are usually very close, to kind of increase the distance and reduce the risk of radiation damage. And then there's often more constipation in Black men and certain other underserved groups. And so that can bring the rectum closer to the radiation field because it's full with feces. And then the overworked staff, as I suggested. We recently published a paper about prostate MRI, which has been a game changer for improving the accuracy of prostate biopsies for men who have to go through a biopsy because of their PSA being high, or because they have an abnormality on their rectal exam with the finger in the rectum. They will oftentimes go for a biopsy. But now we're finding that we can avoid some of those biopsies by using prostate MRI, magnetic resonance imaging. You go in a long tube, a magnetic field is generated around the body, and it can really provide good details of the anatomy inside the prostate. And if there's areas of tumor, it tends to be associated with low water flow through the tissue. And so you can actually detect that on the MRI. And tumors oftentimes will have increased blood flow because they're stealing food and nutrients from the neighbors. And so you can see with contrast, early contrast uptake into areas of the prostate, which is called enhancement, and that can help you detect more prostate cancer. And so it's been implemented in many places around the country to use an MRI before biopsy, but it is less accurate in Black men. I discovered this just last year, and I started talking to people who are writing the new guidelines from Prostate Cancer Foundation for Black men screening, and found out that the MRI was just a little less accurate, and so we shouldn't just rely on it. You can miss prostate cancer in a negative MRI, and so the what's called the negative predictive value is about 90% in U.S. whites, and in large overall populations where you have whites and Asians and Blacks and others mixed together, it's about 90% accurate. But when it's in a Black person, it's about 77% accurate. And so we have to do more to get the accuracy of biopsy and MRI higher in Black men. And there's been very little data on Hispanic men, Asians, and Native American populations and other groups. And so we have to do more in the future with that. But insurance had been a problem. And then having radiologists who were trained on MRI was a limitation for many places. Now that it is insurance covered in most places, and it's just not always available. And so I study biomarker accuracy, which are blood tests or urine tests mainly that are used to tell you about your risk of prostate cancer beyond getting a PSA blood test and a rectal exam. So here are the list of some of them. A couple of them I've actually tried to validate or prove that they work in Black men. I actually validated the Stockholm 3 with folks in Sweden at Karolinska Institute, and shows that it works very, very similarly in Black men than it does in other groups, but you should lower the threshold to be about 11 instead of 15 to define that positive test. So it's very similar though. And then prostate health index assay, which is kind of led in the development at Northwestern, works, but it isn't as accurate. So you can use it as a test to tell you when not to biopsy someone or when to order a prostate MRI on somebody, but not quite the same as it performs in other groups. And so I think that a lot of the ones that are on the market already are shown to work in the general population, but because of that higher risk of cancer in Black men, and I think in lower risk in Asian men, especially Chinese men, the thresholds probably should be changed. And you have to see how it actually works in those subgroups. There's a paper that 4K did themselves. The 4K score is a blood test that includes some genetics and clinical factors like your rectal exam result, your PSA, and it is better. It performs better if you add a term for Black race to the model, which is not how it reports out results now. So I think it performs less well in Black men the way it's used right now. There are genomics tests that have been tested for predicting what kind of cancer test the aggressiveness of your prostate cancer once you already have it. When you think it's low risk and you may want to actively surveil it or not treat it up front, these tests can help patients make a decision about perhaps whether they should go ahead with the surveillance or pursue radiation or surgery or focal therapy up front. But the Oncotype DX assay, I actually validated it in 2014. The others have some data, but not subgroup analysis. So we think it works, but not quite sure. And then PSMA PET imaging is another kind of advancement in prostate cancer detection, not just in early prostate cancer, but if you have recurrent prostate cancer where you've been treated with radiation or surgery or focal therapy, and you think it may have come back because the PSA is rising again. This PSMA PET scan is about 86 to 90% accurate in detecting the presence of cancer in the prostate or other places in that setting, and can even tell you when you have metastatic disease that would have been missed by CT scans and bone scans that we were doing for the last, I guess, 30 years or more. It is helping to change treatment paradigms and even offers a way to treat advanced metastatic prostate cancer by using antibodies targeting PSMA, which is on the cell of most prostate cancer cells, and delivering a radiation dose directly to the tissues. And it can extend survival and keep the PSA from rising further and even drop it. So there's a lot of exciting things happening here. Right now, it's not being utilized by all minority groups. It's not widely available because I think the tracer only lasts 4 to 6 hours in transport. So you have to have a sensor that can have what's called a cyclotron that makes this radioactive tracer, and they have to get it to the hospital and put it into a patient. So it requires that you have a low no-show rate, good insurance coverage, and the facility can afford it. So improving, if we can get the times for the, spread the PSMA PET so that it can either last longer or be more widely spread, you can maybe reduce disparities that MRI is currently causing with the lack of detection in Black men. And I just wanted to say that there are a lot of studies talking about kind of using socioeconomic factors to adjust for the differences in mortality. And I just want to remind people that right now, the socioeconomics are hard to adjust for by putting them in a model. And so we should have take kind of models that say that things are equal and equal access with a grain of salt, simply because the net worth of most minority households are 4 to 6 times lower than the average white household in this country. It's $250,000 for the median income for white males, 44,000 for the Black household, and 62,000 for the Hispanic household. And so that difference means that when you kind of do these adjustments, we may not be able to trust that the equal access setting is as effective as we hope it is. We do think it helps. We're not sure it is a cure-all that some believe it to be. So just wrapping up, there are still disparities in prostate cancer. Incidence is the main one, for Asians and Hispanics being somewhat protected, Blacks being at highest risk, actually behind Puerto Rican men in the US now. So that's still there, and the mortality issues are still there, but a lot of it is reduced when you shop around and get your care at a high volume center where they, or at an equal access center where the VA or military hospital, or in a clinical trial, radiation or surgical trials, provides you better oversight, and people tend to get through the trials and their treatments more readily. And then I would just say that there are MRIs and biomarkers that work, but we may have to do a little bit more to find the right one for you and based off your race and ethnicity. And at this point, and then future research just will involve more minority cohorts. So I encourage you, if you're an ethnic minority and you get diagnosed with prostate cancer, consider involving yourself in a clinical trial, because you can really inform how we get to precision medicine for your racial or ethnic group. So I think I'm going to stop there.
Awesome. So an audience, if you're thinking, I know several times precision medicine is really aiming the treatments, the evaluation at you as an individual. So that's what, when Dr. Murphy keeps talking about precision medicine, that's exactly what we're trying to do. It's patient-centered care that is precise and tailored to you in particular. So, that's really important. And I think we're coming along with that, but it is definitely a work in progress, right, Dr. Murphy?
Yes, sir. I'll be employed for a while.
So I was thinking about a couple things as you were talking. Excellent presentation. And thank you for sharing all that information. When I was out in South Shore at this amazing place called Giving Others Dreams, the acronym is God, but I did a talk for them. And one of the people who came said, I came here for one purpose. I'm trying to understand, she said, for my African-American community, why do Black men, African-American men, why do they have prostate cancer more? Why is it disproportionate? What is going on with that? And, as we both know, we don't have definitive answers for all that, but you touched on a few really important things that I want to make sure the listeners understand. So prostate cancer has been shown to have a genetic, which means hereditary. When we say genetics, we mean hereditary. Your father, your uncle, your brothers have prostate cancer. There is a component there, and they think that some of the genetic variations in Black men may make them more susceptible to higher levels of androgen receptors within the prostate. They think there's different things that are going on in the body genetically, as well as the genetic inheritance of the prostate cancer. And then there's genomics, which he also mentioned, which is the cells themselves. And so genomically, they believe there are some differences too in African-American men in the prostate cancer cells themselves, in your cells as well, besides the prostate cancer cells, just the prostate cells. So I think there's genetic factors, hereditary factors, and genomic, which means how your cells, the structures and factors of the cells themselves. So there's a lot of little pieces. In addition, you mentioned the socioeconomic factors and the disparities there. But what do you think about all that? Because it was really a burning question, and I think a lot of the listeners out there may have that same burning question. Why? Why is it disproportionate?
So you gave a good opening to this already with your description, but what I would say is, if you look at genetic, kind of these polygenic risk scores, it suggests that when you look at across these 400 and some markers that have been associated with risk of prostate cancer, a subset of which are associated with aggressive prostate cancer or lethal prostate cancer, what you find is that Black Blacks tend to have a higher number of those polymorphisms or variations in their genes. Versions of the genes that are not necessarily a mutation, but it's a version of the gene that's associated with higher risk of prostate cancer development. And so Black men tend to carry a higher burden of those risk alleles, they call them. When we did an autopsy study with Dr. Rotimi Neti, that you may remember from the VA, Dr. Albaugh, we found that the autopsy rates of latent prostate cancer that was not detected during life and treated, but cancer that was incidentally found for people who died in the hospital for other reasons, the rates of undetected prostate cancer is a lot lower in Nigeria and Ghana, which is kind of the ancestral birthplace of a lot of the Black people here in the United States. So if our forefathers or foremothers are having low rates of prostate cancer with very similar genetics, and we've shown that a lot of their polymorphisms, the different regions are similar frequencies in Nigerians and West Africans and American Blacks. And so, or they may be a little higher than us, in fact, because we have some, white admixture as well, mixing with white and Native American folks in the U.S. kind of dilutes out some of that frequency. So we think it's gene environment interactions in a lot of ways. And whether that gene environment is dietary, whether it's where people live, the stress that they are under, it could also involve vitamin D deficiency as well. Though there are lots of things that seem to be associated with prostate cancer risk. And when you do twin studies, they estimate somewhere between 42 and 58% of the prostate cancer risk is hereditary. The rest of it is, just living, being older age. And there are other cancers and genetic syndromes that also are associated, like the BRCA2 gene or other DNA damage repair genes or homologous recombination repair genes that can be mutated in families, be passed on from mother to son or father to son. So you can have a mother with breast cancer or ovarian cancer giving prostate cancer to their son, at least that risk is there. And so there's a lot.
Yeah, it's so much to unpack. And that's what I said. Boy, that's a question we could probably spend an hour on when I was out there doing my talk. So because like you said, so then you have those genetic and genomic pieces, but you also have the environment and those kind of things too. So exposure to different things that might take something in your genomics that wouldn't be problematic, but exposure to certain things causes a risk for prostate cancer. So I think there are definitely genetic, genomic, and environmental factors that come into play with that higher risk. And it's interesting. People talk sometimes about diet because of the lower risk in certain groups that eat more of a plant-based or a fish-based and not a meat-based. So there's a lot of different thoughts. We don't know all the definitive answers, but I think those are definitely some of the things that warrant more research and that we're continuing to explore. So,
yeah.
Another thing that comes to my mind was I remember this good friend of mine from church. My church is in the old Cabrini Green area of Chicago. It's Holy Family Lutheran Church. And so it's an African descent Lutheran church. And this really good friend of mine was diagnosed with prostate cancer. And I was explaining to him some of the different factors and stuff. But just to speak to the not always getting the best medical care, when he went to get some of the different things that he did is MRI and different things. And you know how they do a bone scan, make sure the prostate cancer hasn't spread. It hadn't, and that was all good news. But when they told him that, he came back to me and said, I don't have prostate cancer anymore. They said, I'm clear. So, and what he was getting was he heard, and could it be them or him? Who knows? Because we all hear what we want to hear. He heard the good news. There's no prostate cancer anywhere else is really the message from those further studies that he was having done. But he didn't understand, no, you still have prostate cancer in your prostate. It's contained within your prostate. So it can be eradicated because it's only in your prostate, but it's a couple places, and there has to be, all those little things that you look at with each patient and each person and trying to pull that apart for people. But for anyone with, of whatever race, ethnicity, whatever, it can be really confusing to navigate your way through a prostate cancer diagnosis. You hear the word prostate cancer, and it's hard to take it all in and figure out what to do and when to do it.
Absolutely. So, no, I think that's a real thing, and I think it becomes worse if you have language barriers. If you have even English from Liberia or Nigeria or other countries, period, to American English can be a language barrier in some nuanced ways. If there is a history of medical mistrust, we think about medical mistrust as kind of like a Tuskegee or Gila cells kind of a problem with the healthcare system, but there are a lot of reasons for people being suspicious of the medical system. And it will, as late as 1970, there were egregious things happening to minorities in clinical trials funded by the federal government. So I think that there's real reasons for that distrust. There's also something that comes out of not always having access to healthcare. It's one term for it is called John Henryism. Where, as long as you can keep moving, being sick is something that is not going to stop people and make them seek medical care. Because one, can be expensive. Two, there's a conception that doctors give a lot of pills or a lot of medications that are expensive, and they think that we're kind of benefiting financially off of their medical treatment. And then there's this mistrust, right? And so there are multiple reasons why people may not understand that what the doctor is saying when they get to the situation of being diagnosed with prostate cancer. But John Henryism is one where you kind of like, put on your bootstraps and, get tough guy on them. There's also denial, where people just kind of can't deal with the excess stress. So they just kind of backburner that issue until a time when they feel like they can mentally handle it. And so I've had several patients come back 1, 2, 3 years after they were diagnosed. And then unfortunately they had metastatic prostate cancer or advanced prostate cancer and lost their cure opportunities. Some of them have not, but oftentimes goes not the right way.
I think that's very true. And I think even in this day and age, studies continue to show there can be disparities, even with the way that information is given to different patients at different economic levels, different racial diversities and things. And it's really sad to think in this day and age, we still have all these disparities in care. And I found it, but not just even my other friends, of course, like you, all of our friends with prostate cancer come to us and confide in us. And often you're not there when they get the information, and they don't seem to have all the information they always need, but you're not sure if they just didn't hear it all or if it wasn't given. It's really difficult to guide your way through it. And like you said, we have some wonderful medical centers here, and in our minority communities, we have some really good centers there that really are dedicated to those communities too. But I think what I always try to do in my prostate cancer support group is I highly encourage people. There is never anything wrong with getting second opinions, and I really tell them I would go to a major medical institution to do a second opinion if you got it at a smaller one to begin with. where there's a group of students and people talking about your situation behind the scenes. They are really pulling apart what's going on with you. And we have some excellent centers that do that here, including Northwestern, where you are, University of Chicago, North Shore Endeavor, and Loyola, some very, very good medical institutions where they can do that.
No, we're blessed. And our patients who do seek care are blessed. And I saw in your chat that there was a person talking about rebuilding medical mistrust.
Yeah, let me give you those questions. Hold on, I have that one. Let's see. Let me give you the first question. It's some of us men in minority communities are hesitant to see a doctor because of mistrust. So you led right into this one perfectly. What's the best way to start building that trust back for men like me?
There's a couple things. Trust, so this is from my MBA part of my personality, whoever asked that question. Trust requires a few things. One of them is a lack of information asymmetry, meaning that the person giving you the information or giving you the opinion has way more information than you do when you go and talk to them. And so the way that I kind of work on that is to teach myself, and I tell my patients to teach themselves a bit about their diagnosis if they have one before they show up. If it's, I have a high PSA level, right? When you go into the doctor's office, ChatGPT, the Google Copilot AI that you can Google now with on the computer can give you some summaries about really basic definitions. What is a prostate? What is PSA level? What is a biopsy? So I know that sounds like putting work on you as a patient, but it is an important homework assignment because no one's going to understand your values about what you want to achieve with care like you will. And so a doctor will almost always go more aggressive or kind of go with the thing that will basically cure you the best, right? Mm-hmm. And oftentimes patients have different goals than doctors are unaware of. And so kind of coming in with a little bit more knowledge about this, writing down the questions you have when you show up, and no more than 2 or 3, right? Because if it's on after the first visit, you only have like 10, 15 minutes with that doctor. So you have to be efficient with your situation. The other bit is about trust is really doing a little bit of shopping with your friends who seem to have a good relationship with their doctor, with your medical friends who may know people who work on the inside of the institutions to give some advice. And then if you don't love the fit, you may have to find someone else that you do vibe with better or connect to more so that you can feel like they're on your side, right? That you have what I call a therapeutic alliance where you kind of are doing the right thing, but they also are considering your wishes, your values, and give you some homework assignments sometimes to help you understand your own diagnosis better. Some reading.
It's so interesting because as you were talking, I'm writing down, and I was exactly what you were saying about how there is nobody on the face of the earth that's going to advocate for you better than you. So I love that you brought up that point, and I want to draw that home for all of our listeners. And no one will advocate for you like you. You are your greatest advocate. And when you walk in that office, yes, you should have your questions written down, because if you're like me, you are never going to remember them. And bring your partner if they're available and you have a partner, because my wife and I say all the time, between us, the two heads, we got a brain going pretty good. So having a partner there can really help to help you remember what you heard, to help you recall, but also have those questions ready ahead of time. And maybe your goals and what's important to you and what you're concerned about, so that your doctor knows your priorities and your goals. I think those are some excellent, excellent ideas. Also, Vic, I put in there the zerocancer.org go to that one first. So I run a group at Gilda's Club, but there's online groups. There's tons of groups out there where you can talk to other men with prostate cancer. My group is run by a survivor, myself, and a social worker at Gilda's Club. But there is a wonderful group for people with alternative lifestyles, gay, lesbian, different trans, all that kind of thing. There's an excellent support group in Zero for those men and male identifying or female identifying people with penises. There are wonderful resources, and it gives you another opportunity to talk to other people about it, especially other men who've gone through prostate cancer treatment, and they have all kinds of different support groups. You'll see help and support, and there's a drop down. There's so many different groups. I've been involved with them way back since they were Us Two. Adam's been involved. They're a wonderful organization to help you understand more and answer your questions, for sure.
We started their virtual support group for Black men too.
Yes, that's an awesome group. Yes, I think I've spoken. That is a great group. Thanks for bringing that up. There is a group specifically. I forgot about that group. That group's awesome, and I get an email from them every month. So
we did the work, early work, and I think it's paying off. I'm glad that it's still alive.
And that's an awesome group. It's a really, really good group. Okay, now the next question where I'm going to put up there. What are some of the biggest barriers that prevent early detection and treatment in minority communities, and how can we overcome them?
I have, well, the first part I can answer very well. The overcoming is where we all need to work together. Yeah. But my answer would be awareness. We talk about breast cancer way more readily. It's a pretty private part, but people know about their mom's breast cancer, their sister's breast cancer, coworkers' breast cancer.
Women are the best advocates for their health. Men, I'm a man, so I can say this. We are not so good. The breast cancer, this whole city is pink in October. And in September, when it's Prostate Cancer Awareness Month, you're like, where's the blue? Where's the blue for prostate cancer?
I know. And, I will tell people that, you have to, what I noticed is just the conversations around the table that people have around their health. Certain cultural groups, I've heard Chinese folks are very reluctant to talk about cancer and those kinds of diagnoses. It used to be very, very true in African-American groups as well. And things that are associated with a lack of machismo or masculinity may be really a problem for certain Middle Eastern and Hispanic groups, right? Mm. And these are stereotypical kind of cultural norms that I've heard to be true. Mm-hmm. And so it makes it so that we really don't talk about things that can threaten our erectile function, our fertility, because if you get your prostate removed, you're not having babies. Mm-hmm. And if you're leaking urine on yourself, it's already just a human embarrassing moment, right? So for people to get up and talk about this with their family members is really hard. And I think if you have the good outcomes, where there are a lot of people who do have the good outcomes, they can talk about it from the rooftops. But if your sexual intimacy is threatened with your partner, that can change a lot about the dynamic you have with your partner.
Definitely.
Where it's not just, you're not having sex and you're both irritable. It can be how you all show love, and that can be strained. It can also be how you exchange favors.
Yeah.
Right.
Yeah.
So someone is no longer able to have sex. Well, maybe you're not getting dinner put in front of you anymore.
Yeah.
And
yeah.
So I just think that, there are a lot of reasons why it doesn't happen, but it needs to happen.
Yes.
I say penis, vagina, prostate, and erections like I say butter.
Me too.
and so I can throw some people off with that. In fact, some of my friends have warned their girlfriends that I may do that in a random sentence. It's not being flirtatious.
I love it. But you're right, because we're trying to let the world know we're on a mission to say, and this is why we did this particular podcast, is we're here to say you need to be aware. Prostate cancer is the #1 non-skin cancer in men, and it's more prevalent in African-American Black men population. And I thought that was so fascinating about Puerto Ricans and that as well. So you got to get checked. You got to be aware of it. Here's the thing. When you have symptoms for prostate cancer, you got a big problem because you don't get symptoms early on at all with prostate cancer. You will only know you have prostate cancer early when you could intervene or just carefully watch it. They don't always have to intervene, but they need to know it's there and need to be aware and watching. So it's very, very important to get your PSA and your digital rectal exam. When I was 40, and I have no history, I'm Caucasian, German, Irish, English mutt, but my doctor's like, roll over. You know what's gonna, you know where we're at with this. And I'm like, I'm gonna argue with them. I'm like, you already got my PSA. Of course, I'm gonna do this. And that's just getting that baseline. If you're younger than that, you may never need it if you don't have risk factors like a family history or the disparities with the African-American Black men. But get a baseline, see what's going on, and be on top of it. Nobody advocates better for you than you, because if you can't catch it early, here's the thing. Prostate cancer is very, and we don't use this word loosely, curable. Now, there are things, as we were just talking about, sex and intimacy. There's a lot of things to balance out in your decision about treatment for prostate cancer, but there are ways to cure that. So definitely, I am going to pull my. Yeah, go ahead.
Just one thing, which is that the family history thing is a risk factor, right? But most patients with breast cancer, most patients with prostate cancer do not have a family history of the disease. More than 80% of people who are diagnosed have no family history. So you cannot use symptoms. You cannot use that you think you know how your body feels because you're so attuned with it. You can't use a family history of cancer in your family to tell you that you should get screened for prostate cancer.
Yes, definitely.
Or breast cancer for that matter. It's the age, it's other risk factors, but it's not in this country based off of your family history and your feeling healthy.
And I think too, that's the really difficult thing for our patients when they're diagnosed with prostate cancer, because they're like, I had no symptoms, I'm fine. And now you did surgery, you did whatever, and I'm not okay. That's the challenge to it. So it's all a balancing act. And like you said, some people have great outcomes with surgery, radiation, active surveillance, but some people have struggles, and you're going to hear about the struggles because people talk about their struggles a lot and they're real. So it's finding out for you in your particular circumstance. But you said it perfectly. No one's going to know they have prostate cancer in a timely manner when you have a lot of alternatives and things without the screening and the awareness. So it's really, really important to do that. So I really appreciate all the different things. You've brought up so many good points. It's been such an excellent episode. I'm going to do a little centering exercise and we are going to close out our time. So if you have been here before, you know that what this time is that we're at now. Lots of information. You might feel a bit overwhelmed because it can feel overwhelming. Your head didn't spin off. I hope you're doing okay. So let's take a moment to return to our authentic, peaceful, true selves, because that's who you really are. Your true self is peaceful and authentic and worthy. Get into a comfortable position. You can put your feet flat on the floor. You can be sitting. You can be resting. You figure out what is a comfortable position for you. If you're comfortable, gently close your eyes. Breathing is powerful. Take a slow, deep breath, filling your lungs from deep down in your gut. Fill your lungs. And then exhale. Slowly and gently exhale through your mouth. So in through your nose for about 4 counts. And exhale through your mouth gently for about 5 counts. Continue that breathing pattern. 4 counts in with a deep, full breath in your nose, and 5 counts out with a slow, gentle exhale. With each inhale, breathe in awareness of your miraculous, incredible body. Breathe that in. With each exhale, release any tension or judgment. Judgment is what causes suffering. Stop judging. Let it go. Don't let that live in your body. Now, gently bring your mind to someone you love, a father, a son, a friend, or even yourself. Self-love is critical. Imagine wrapping that person in compassion and care. May that knowledge help protect, heal, and empower yourself or that person. You are more than your illness or your disease. You are inherently worthy and enough. Your body is amazing and miraculous. Rest in gratitude of who you truly are. Take one more deep breath and exhale gently. And when you're ready, bring your attention back to your space. And as you move forward, infuse your life with more of that compassion and care that you envision. Well, I am so thankful for our guest, Dr. Murphy. Let's go to what's up next week, Vic. Tell us what's up.
Sexual health is more than just pleasure. It's one of the most accurate reflections of a person's overall health. In this episode, renowned urologist Dr. Mohit Khera joins Dr. Jeff to explore how sexual function serves as a powerful barometer for physical, emotional, and relational wellness. From erectile dysfunction in men to female sexual dysfunction in women, these conditions are often early indicators of deeper issues. You'll learn how healthcare providers diagnose and treat sexual dysfunction using an integrative, evidence-based approach that addresses the whole person, not just the symptoms. This episode empowers you to understand sexual health and its role in overall wellness. Take charge of your health today. Join us on August 19th at 7 p.m. Central Time to learn more.
That is going to be an awesome episode, and my friend Dr. Mo Khera is excellent. You're going to really enjoy it. But today, we had a great episode with you, my good friend. And thank you, Dr. Murphy, for sharing your expertise with all of our audience today.
Thank you, Dr. Albaugh, for having me. It was fun as always. We're going to work together again soon.
Definitely. And listeners, thank you. You're what this is all about. And please, be aware, prostate cancer is the #1 non-skin cancer in men. And if you have it, there are treatments and there are even cures. So get screened and be well. Thank you.